Yeah, I mean, my lab focuses a lot in the castration-resistant setting and maybe perhaps more oncologic setting. So today I'm going to try to tell a story about what our experience at diagnosis, focusing on de novo metastatic prostate cancer, so prostate cancer with mets at diagnosis. And kind of throughout that story, try to thread in some of the lessons we've learned from the later stage disease and perhaps whether that can be translated earlier into your kind of practice or at least, experience. So mostly we'll be aware that the de novo metastatic prostate cancer represents a small proportion, a small minority of initial diagnoses, but actually contributes to about half of all prostate cancer-related deaths. So that tells you the trajectory of this disease. And the incidence is thought to be rising due in part to improved imaging modalities, things like PSMA PET and so forth, actually picking up more metastases at diagnosis, but also reduced PSA screening in this sort of newer era. So historically, these men were managed with androgen deprivation alone, so just essentially standard hormone therapy like any metastatic prostate cancer patient. But there's been a series of recent large randomized phase 3 clinical trials that have shown benefit for various combinations of androgen deprivation therapy with AR-targeted inhibitors like abiraterone and also with taxane chemotherapies. And there are other targeted therapies such as PARP inhibitors that are also being tested in this setting. So we have this situation of this increasingly congested treatment landscape, both in the CRPC setting, in the resistant setting, and also in the castrate-sensitive setting. So this is sort of what the landscape looks like from a treatment point of view. We have this sort of treatment intensification phase in the metastatic setting. And then we have lines of standard therapy which actually now overlap with the way that metastatic castrate-sensitive prostate cancer is treated. And of course, experimental treatments as time goes on. So the question becomes, how do we determine the optimal therapy and sequence of therapies for these patients? When there are multiple standards of care, how does one decide whether a taxane is appropriate, whether abiraterone is appropriate? And furthermore, later on down the line, how does one decide potentially what targeted therapies, what experimental treatments, what clinical trials are appropriate for each individual within this huge gamut of disease? So we see that there are new opportunities, particularly in the CRPC setting, for molecular subtyping. So there have been a huge number of data come out that leveraged metastatic tissue biopsy in late-stage patients or rapid autopsy programs, so actually taking metastases from deceased patients and studying them to find out what's actually going on in the lethal setting. And as you may know, mutation rates in prostate cancer are reasonably low, but there are lots of copy number changes. There are lots of changes in the structure of chromosomes, the number of chromosomes, so things like deletions and gains and so forth, highly aneuploid cells. So we're able to see things like androgen receptor changes, DNA repair changes, and I could go on, but the sort of take-home message is that one can actually group different castration-resistant tumours into different categories from a molecular point of view, from a genomic point of view. So you can kind of do this sort of molecular subtyping or stratification. The question becomes, ultimately the question from my point of view, and I'm sure even more so from yours, is, well, what's the point? Does that actually tell you anything? Is there any clinical relevance to this? So I'll give you a few illustrations here of the difference between localized and metastatic CRPC. And so that's all, put this in context of what I'm going to talk about when it comes to castration-sensitive metastatic disease, which you should imagine fits somewhere in the middle. So ETS fusions, which you may have heard of, and SPOT mutations seem to have equal prevalence in both the sort of deadly setting and the initial diagnosis stage, which kind of tells you that it's something involved in tumor genesis and the very beginnings of cancer development rather than perhaps driving progression and so forth. But there are other changes that increase in prevalence as you look later down disease. So FOXA1 is a gene, is a transcription factor, a pioneering factor. That's more commonly altered. P10, which is part of the PI3 kinase pathway, explodes in terms of its prevalence. And so does P53. Almost more than half of patients in the late stage setting have defects within the P53 gene, which is a critical gene for for apoptosis. So when you've lost p53, you now have a cell that perhaps is less able to apoptose, and you can imagine why that's a benefit for a cancer cell. Add on top of that, in the CRPC setting, you have huge gamut of changes to the androgen receptor, whether it's mutations, amplification, structural rearrangements, as well as an increase in the amount of DNA repair defects. So the point here is that there is actually a difference between localized prostate cancer and late-stage setting at the underlying genomic level. And so that kind of tells you that there are changes that are associated with aggression within the tumor itself. So it does sort of, lead to the hypothesis that presumably these, if you detected, let's say, a p53 mutation up front, that may actually be representative of a more aggressive tumor than one that didn't have. This is a nice paper from this year that summarizes some of those differences if you're interested. So when we come back to this picture, I like to kind of think, well, if we could take this sort of molecular subtype map and superimpose it on different parts within the treatment spectrum, can we start to say, okay, well, is alteration in gene X linked to first-line therapy response? And so that's essentially what my lab tries to do, is to take this blueprint and try to find out if there's of any relevance whatsoever in the clinical setting. The problem has been that although we have this sort of new wealth of knowledge about these cancers from tissue biopsy programs, the tissue biopsy itself in the metastatic setting is very unlikely to become routine. And so, part of that is because it's very expensive, it's obviously morbid to the patient to drill into bone tissue, and a lot of the time, bone biopsies fail. And you can imagine why. I mean, it's very challenging to actually identify a lesion that's suitable for biopsy. Let alone to actually biopsy it and have enough DNA and RNA left over. Even a CT-guided biopsies are still extremely challenging, even in the research setting. So how do we actually molecularly subtype de novo metastatic prostate cancer? Is arguably even harder. So the majority of these patients will not undergo surgical management of their primary tumor. So you're not going to have a nice big RP specimen to go back and look for various genomic changes. The only source of tissue is often just a confirmatory prostate biopsy, essentially. So you might have 1 or 2 cores of FFPE tissue to look at. And so luckily, technological advances mean that we're a little bit better at studying these tiny, minute amounts of fixed tissue than we used to be, say, 5-10 years ago. But we still don't know that if you have a bit of information from the primary tumor in a patient with explosive metastatic disease at diagnosis, is that actually representative of their metastatic disease? Can you really draw conclusions about the rest of their disease from that small core of tissue from their primary site? And of course, in this setting, very rapid decisions are required. We don't necessarily have the luxury of months to wait and try to work out, well, what's the best setting, what's the best combination to throw in the mix here. So you know where I'm heading here, towards the liquid biopsy as being perhaps an avenue of definitely research and potentially clinical utility. So the liquid biopsy is not new. This is a page from a French pathologist's paper in 1869. And he was actually the first person to notice in one of his patients with cancer that he could see in the blood, in a small blood sample from that individual, cells that looked a lot like the cancer. So he was the first person really to be credited with saying, hey, there's some tumor material in the bloodstream in this cancer in this person that has tumors. Fast forward 150 years, it's taken all this time to actually get up to speed on these things. But the reality now is that plasma circulating tumor DNA, which I'm going to introduce in a minute, is now very well established for profiling castration-resistant prostate cancer in the research setting. So we've been fortunate to lead several large ctDNA-based studies. We have a validated research assay, well, really a series of assays, specifically for late-stage prostate cancer. And so we're involved in multiple correlative clinical trials, and we're also evaluating ctDNA as a predictive biomarker in prospective trials for CRPC. So it's a very exciting era, but how do we move this to de novo metastatic disease into the castrate-sensitive setting? So I'll begin with just a little bit of background here. What is ctDNA? So you'll be aware that tumor cells can circulate in the blood all the time, but that's actually pretty rare. If you have a blood tube, you're only likely to find a few circulating tumor cells. So DNA, cell-free DNA is quite different. So DNA is released into the blood by all the cells in our body. So any sort of proliferative population that's turning over within your body is releasing DNA just through apoptosis. And that's available in the bloodstream for a short proportion of time. So in cancer patients, some of that DNA is coming from their cancer because it's a proliferative bundle of cells, and so it's turning over all the time. So DNA has a very short half-life in the blood, so it's sort of minutes. And it's rapidly cleared by the liver, the kidneys, and endonucleases within your blood. So for a few minutes after a cell's died, its DNA is theoretically available to you somewhere in the bloodstream. And the same goes for pretty much anything that was within that cell. So you can extrapolate that to RNA, exosomes, any sort of cellular body there is available for a few minutes after those cells have died. And ultimately, the amount of tumor DNA in your blood in relationship to all the normal cell-free DNA is very much related to the proliferative tumor burden that you have. So in the setting of sort of a subclinical cancer, you would have very, very low amounts of ctDNA. And so when you hear people describing efforts at the moment to try to use the liquid biopsy to diagnose cancer, you have to be aware that sometimes the amount of ctDNA blood in the blood is reaching homeopathic levels of tumor DNA. And the mathematics are that sometimes you may need 100, 200, 300 microliters of blood just to detect one mutant molecule. At the opposite end of the spectrum, in the setting sort of we deal with, it's really the opposite. Sometimes close to 100% of the DNA that we're pulling out of a blood draw is tumor-derived. And so it's really the opposite end of the spectrum. And those are patients that will have very, very high burden of metastatic disease throughout their body. So this is a question I get a lot. And so you'll have to excuse the dodgy cartoons here, because these are just made in PowerPoint. So how do you actually detect tumor DNA when you have a blood sample? I think this is really a critical part of the research, and not everyone, it's not immediately obvious. So if you have a cancer that's represented here by the cancerous cells and some stromal cells around the outside, they've all got DNA in, obviously. And here I'm showing that there's potentially a mutation, a p53 mutation indicated on one of the DNA strands here within the cancer. So the cancer has a p53 mutation, the rest of the normal cells in your body do not. So if you had a tissue biopsy of this, it would be very simple. You'd just sequence all of these cells, and you'd be able to identify that you had a large number of p53 mutations here that you wouldn't normally expect, and they must have come from the cancer cells that you specifically selected. Well, what if you just have a blood sample? Well, so what happens is when cells apoptose, which happens a lot in you can't see it, which happens a lot in cancer, particularly proliferative cancer that's turning over rapidly, it's shedding these fragmented genomes into the bloodstream, and so this is mixing with all of your non-malignant DNA in the blood until it's degraded. So when we get a blood sample and we pull out the plasma fraction of that blood, within there is that mix of DNA, both tumor and non-tumor. And so what we do is we sequence with next generation sequencing all of those fragments. Essentially, we find out technologically what the base pair makeup of each of those fragments is, and we can then sort of align them and say, well, hey, we detect a few mutations here that are not present in the patient's germline control. So we might use whether we use a benign piece of tissue or we use the leukocyte population of white blood cells as a control. We say, hey, in most of this patient, he doesn't have a p53 mutation, but we're now identifying this in the blood. So this must come from a somatic clone. You don't necessarily know yet that this is coming from prostate cancer, but this must come from a somatic clone. So that's really the concept of ctDNA, and it can be extrapolated to any cancer. So there are a whole bunch of caveats that I'm not going to go into, but I will explain one quick slide because it's kind of interesting. It's turned out that clonal hematopoiesis is a key confounder for ctDNA analysis. So this is a concept that as you age, your white blood cell lineage can accrue somatic mutations, particularly in some critical tumor suppressor genes like p53. JAK1 will be another common one, ATM, KRAS, genes which actually confer an advantage to your underlying progenitor cells for your white blood cell lineage. So if you don't in parallel sequence the white blood cells in a patient, you might identify a mutation that's actually just present in a white blood cell clone and essentially erroneously assign that to being from your cancer. So I don't know if that makes sense, but this paper came out this year, really did a great job of summarizing this. So they looked at a whole bunch of patients that didn't have that matched white blood cell profiling. And they found that about 5% of those patients would have had at least one mutation erroneously attributed to cancer when it was actually coming from clonal hematopoiesis. The other problem is that you must be confident that the DNA, that the mutations you're seeing is coming from metastatic prostate cancer. Now, we don't face such a big problem as you might do in the diagnostic setting, because obviously we know this patient has explosive metastatic disease. We know he's got a PSA of 2,000. By and large, we're pretty confident that the vast majority of disease in his body is of prostate cancer origin. But we still see problems from time to time, and I'll walk you through one of them. First, here's an example. Now, this is a slightly complicated plot, but what it's showing is a patient that's sampled in the CRPC setting prior to abiraterone and after abiraterone. And what we're looking at here is a few of the mutations that were detected, and so the bar height is representing the prevalence of those mutations in the blood at baseline, and then the mirrored at the bottom at progression. And you can see by and large, most of the mutations are detected at both baseline and at development of resistance. But there's a few changes overall, these two mutations disappearing, a new androgen receptor mutation arising. Overall, the detail doesn't matter. All that matters is that this particular pattern of mutation, the type of genes we're seeing, can really only be prostate cancer. For a start, if you see an androgen receptor mutation, it can pretty much only be prostate cancer. So here we can be relatively sure that at both baseline and progression, what we're sampling is his prostate cancer. And we're seeing a change in the androgen receptor in response to therapy, and that's likely related to the resistance in this patient. However, this is not always what we see. So here's another patient, same kind of scenario. We had a baseline sample that actually, again, had a profile very consistent with prostate cancer, so a FOXA1 mutation. You'll have to take my word for it, but it's extremely unusual in other cancers. However, we sampled him at what was determined to be clinical progression on abiraterone, and we saw all these changes, and we just thought, holy crap, we found this new expansive clone that's arisen out in response to abiraterone. And then we kind of thought, hang on a sec, these mutations are not that typical of prostate cancer, so what's going on? And a few weeks later, the patient was essentially diagnosed with metastatic bladder cancer. And so it was deemed that actually his prostate cancer was still being kept under control by Abbey in this setting, but he now had a metastatic bladder cancer. And so what we were sampling there was in fact his bladder cancer. So these are sort of problems that we face in ctDNA, and I think we've been in a fortunate setting that because having spent 3-4 years pretty much only researching this, we're aware of some of these problems, but this is not necessarily indicative of the whole community.
So Alex, coming forward,
yeah.
Every lab will have to do white blood cell.
Yes, absolutely. Particularly in an aging population. Yeah. Yeah. So I'm not going to go into detail here, just a sort of snapshot to say that the methodology we use has been refined over the last few years, and essentially what we do is, rather than sequencing the whole genome, all the cell-free DNA, we sequence specific genes and specific regions that we think are relevant to prostate or bladder or whatever cancer we're profiling. And that gives us the information that it gives us those key molecular subtypes that I described earlier, the key events that are recurrent in different cancers. And we've also, in the past, we've grounded our work in paired studies of metastatic tissue and cell-free DNA. So here was an example paper published about a year ago, where we compared for 45 patients a metastatic tissue biopsy and the matched cell-free DNA, and just satisfied ourselves that, yeah, the mutations, the deletions, the changes we were getting from the blood sample were the same as what we get from a tissue biopsy sample. So this is sort of sanity checks that allows us to be confident about what we see in the cell-free DNA. They're critical for sort of moving things forward. You have to know that what you're testing represents the gold standard, which is tissue. However, the ctDNA is basically unexplored in castrate-sensitive disease, including patients that are presenting with de novo metastatic disease. And so it really remains completely unclear whether exposure to ADT, or hormone therapy, even for just a week or so, actually affects ctDNA levels. And in fact, some have hypothesized that ctDNA might go up after a Lupron shot or other, because you might have induced additional apoptosis and cell death. It's important because those decisions for treatment combination that I was describing earlier are likely to come after ADT is initiated. My understanding of how these kind of patients are managed is often they might turn up in ER at 3 a.m. and someone somewhere gives them a Lupron shot after a few days, and they don't necessarily come back in for these sort of longer term decisions until later. So, if you want to make these decisions, you may be looking at a patient that's already started ADT. So our objective overall here was to determine whether ctDNA is abundant in this setting, and whether you can actually get additional information to what you get from a prostate biopsy. So can we give you guys another sort of tool to use in your decision making? So we prospectively enrolled 53 patients diagnosed with de novo castrate-sensitive prostate cancer, almost entirely here. So many of these patients will be ones you may have encountered or had some sort of contact with. Some came from the cancer agency via Kimchi. So thanks to Alan and Martin and Peter, who sort of corralled and got blood samples, and those of you in the audience as well. So obviously a confirmatory trust-guided biopsy was performed in most patients. There are actually 3 where diagnoses were based only on clinical factors, so I'm presuming sort of super high PSA, that kind of thing. And all patients underwent a blood collection within 50 days of diagnosis. So here were the cohort characteristics. As you won't be surprised, median PSA extremely high, and Gleason grades in the biopsy specimens of extremely high, although you'll note there was actually Gleason 6. This clearly was disease undersampling in a sort of a single confirmatory biopsy core. You can see there's a large number of patients with bone metastases. And quite comfortingly, given that we're a clinical research setting, it turns out most patients actually have had treatment intensification anyway. So we performed plasma cell-free DNA sequencing in all the patients. There was one individual that failed. And we were also able to perform the identical sequencing approach on the tissue biopsy from 48 of the patients. There were 3 that I mentioned that had no tissue biopsy, and there were 2 that when we retrieved the blocks had no tumor tissue left in their block after those initial H&E slides were taken by pathology. So what did we find? Well, you're probably not going to be surprised to this, but actually ctDNA is highly abundant in these patients. So what you're seeing here is a bar plot for 35 of those patients that were completely treatment naive when we took the blood sample. And each bar represents an individual patient, and the percentage represents how much of their blood cell-free DNA was tumor-derived. So you can see the patient on the far left, it's more than 80% of his cell-free DNA was tumor-derived. And you can see how this tails off towards the end. There's a huge difference here. But overall, 3/4 of the cohort having detectable ctDNA. It's actually very, very similar to what we see in the CRPC setting. So 2 of our studies here enrolling in total 300 patients. And using these same sort of cutoffs, we've got sort of 50-60% and 70-80%. So we're sort of really fitting within that CRPC spectrum as well. However, there were 18 patients within the study that actually turned out to have received a few weeks of prior androgen deprivation therapy before the blood sample was collected. So we were extremely interested to say, well, is there any difference in the amount of tumor DNA in the blood? And there was. So there was a huge reduction in the amount of ctDNA. So the median ctDNA fraction, the percentage of cell-free DNA, was only 1%, and you compare that to 11% over here. This was a significant difference. And in fact, in a few patients, we were able to collect serial samples during their first week. And so this shows 3 of those patients. And you can see declining circulating tumor DNA throughout that week. So we can't rule out that after, let's say 1 or 2 hours of exposure, you may have a spike, a transient spike in ctDNA. But this has big implications for the timing of plasma collection for any sort of correlative research studies or sort of prospective trial designs that are going to be based on blood decision. So did we observe any relationship between clinical metrics and the ctDNA fraction? This is a little bit complicated, but the numbers are fairly small, but we did begin to see patterns. So we saw that patients with visceral disease, every single one had tumor DNA detected, whereas the patients that had, say, lymph node only or a smaller number of bone mets were less likely to have tumor DNA. So that sort of fits generally. The higher burden disease you have, the more likely you are to have tumor DNA at diagnosis at high levels. And so it actually turns out, this is a bit of a segue here, and a shout out to some of the other work that's going on in the lab. You can actually predict how much circulating tumor DNA you're going to have in a patient just from clinical metrics alone. So we have a sort of a paper we're trying to publish at the moment that presents an algorithm for doing this in a simple web-based tool, particularly for urologic oncologists and oncologists to be able to plug in ALP, PSA, metastatic burden and find out, is there any chance that my patient's going to have circulating tumor DNA? Is this going to give a result at all? And so things like liver metastases, lung metastases are a strong predictor. But so is, you won't be surprised, lactate dehydrogenase. PSA is a pretty poor predictor of ctDNA presence and volume in the blood. And so again, that kind of fits in the later stage setting when PSA becomes less linked to super aggressive disease. And so, you won't be necessarily surprised to learn that the burden of circulating tumor DNA you have in your blood is actually strongly prognostic. So this is from a prospective clinical trial enrolling 200 patients. We've performed the ctDNA quantification, and if you split into 3 groups based on ctDNA abundance, you can see the patients with the highest amount of tumor DNA do extremely poorly over time. So that again fits that what we're measuring here is sort of closely related to the burden of proliferative disease and overall prognostic metrics in these individuals. So I think there will be opportunities when there's larger numbers in this type of analysis to do a similar thing in de novo metastatic prostate cancer to say, okay, is this patient going to have any ctDNA? Is a blood test going to be worthwhile in this situation? So what did we do with the data that we had? So we combined the information we were getting from the blood sample, from the ctDNA, and from the tissue biopsy to create this composite profile for each patient, where we've got sort of measures of the primary tumor and potentially the metastatic disease from their blood sample. And so we looked then at those molecular subtypes that I described earlier. And so what I'm showing here is the frequency of some of those changes in our cohort, which is represented in the intermediate color, in localized disease and in castration-resistant prostate cancer. So you can see, for example, that androgen receptor changes are only ever identified in castration-resistant disease. You never see them in localized disease, and likewise, you don't see them in castrate-sensitive prostate cancer. But something that stood out straight away was that these profiles that we're seeing, with the exception of the androgen receptor, were very, very consistent with what we'd expect in the lethal castration-resistant setting. So that sort of fits that these tumors are primed for CRPC progression. They have aggressive genomics that are much more similar to castration-resistant disease than they are to localized prostate cancer, to curable prostate cancer. As an example, I've mentioned p53 mutations before, but they were present in half of our cohort. Now that's triple the frequency of localized disease. It's hugely different. And so I mentioned earlier that these are sort of not a good thing for a cancer cell to have. Well, here's a piece of data from our laboratory showing that in the CRPC setting, if you detect a p53 mutation, you're really detecting something associated with very poor outcomes. So this is PFS on either abiraterone or enzalutamide in patients that have one p53 defect or 2 p53 defects, i.e. both alleles inactivated. And you can see a sort of almost beginning of a dose level curve. We're not the only ones to have observed this. There are a couple of other papers from this year showing p53 is a very strong prognostic marker in castration-resistant prostate cancer. So I think, potentially in the de novo metastatic setting, in the castrate-sensitive setting, it's likely also to have prognostic potential. That's not something we've assessed yet, but I think as numbers grow, that's a clear area to think about, and potentially something that could be explored for treatment intensification, a biomarker treatment intensification that's completely untested to date. Another thing that stood out as quite interesting was BRCA2 mutations, which were already, just based on a few in our cohort, more common than we'd expect in localized disease. So you've probably heard quite a lot of buzz about BRCA2, particularly germline mutations at the moment in prostate cancer, which were previously under-recognized and now sort of assuming more and more relevance in prostate cancer. It turned out that actually 20% of these patients had a defect in a DNA damage repair gene. So 4 of those were BRCA2, but there were a whole slew of other DNA repair genes that were altered in these patients. This is drastically different to what we'd expect in localized disease. And so what that is underlying is a genomic instability in these tumors, so sort of an ability to evolve and accrue further deleterious genetic alterations and sort of augment the cancer-driving abilities of those cells. We even identified a case that had a mismatch repair deficiency. So these are associated with extremely high mutational burden, something very unusual in prostate cancer, the kind of thing you'd see in colorectal cancer, for example. But one patient, he did remarkably poorly. I think he died within 6 months of diagnosis. So again, BRCA2 mutations are associated with poor prognosis across the disease spectrum. So there was even a paper in European Urology yesterday that showed that germline BRCA2 mutations in the active surveillance population are significantly associated with upgrading from Gleason 6 to 7, and not just 3+4, but to 4+3 cases as well. So, no matter where you look throughout the disease spectrum, you find that mutations in DNA repair genes are linked to poorer outcomes. So, what does it mean if we find one of these in the castrate-sensitive metastatic setting? Well, I think, we can probably extrapolate this data to that. And so, this curve is based on fairly immature data, so really take it with a pinch of salt. But this is just looking in those 53 patients that are in our study here. How did they do on hormone therapy in combination? Well, the patients with DNA repair defects are already doing significantly worse than those without defects. So we're sort of saying that the way that we're treating these patients at the moment is perhaps not as optimal as it could be. And there are alternatives, or let's say opportunities for treating these cancers beyond standard of care at the moment. So we have experienced patients where with BRCA2 changes that have had dramatic responses to platinum-based chemotherapy. This was a patient with small cell prostate cancer who had his tumor was completely null for BRCA2, 2-copy deletion of this gene. And he had basically complete response to platinum chemotherapy despite having brain metastases and liver mets and so forth. And he's still alive 3 years later. And you'll probably all be aware of this famous paper in the New England Journal from 3 years ago that showed that olaparib, which is a PARP inhibitor, seems to have a very strong effect in tumors that are BRCA2 null and have other DNA repair defects. So I think, one other point, of course, is immunotherapy, which seems to have efficacy in patients that have those really high tumor mutational burdens. Very, very rare in prostate cancer, but for a subset of men, they do seem to derive response, and that's probably again linked to DNA repair defects. So when we go back to this curve and we think, well, I think there are opportunities to move this line upwards. Shift this line upwards with the appropriate combination therapy. Of course, this is all theory at the moment. It has to be actually tested in clinical trials. But I think we're seeing a potential for those molecular subtypes to maybe help guide how we use some of those new therapies. So in the last sort of handful of slides, I just want to say, well, I want to look at what we're learning from the blood sample versus the prostate biopsy, because we're all, in our lab, we're very, very aware that the prostate biopsy is the gold standard, and there's no desire here to try to replace that. It's more sort of what can we augment from a blood sample in addition? So it's really difficult to try and compare the two from a start. Where do you begin? They're giving different types of information, and how do you say which information is better? So we came up with a few different measures of doing this. So one was to say, quite simply, well, how much tumor DNA are you getting from the blood sample versus the prostate tissue? And remarkably, there are actually several cases. What we're looking at here, I should explain, is the percentage of tumor DNA within the blood sample up top, and mirrored down the bottom is the percentage of tumor cells within the tissue biopsy that we obtain. Those needle biopsies, diagnostic cores. And so there were actually cases up this end of the spectrum where there was more tumor DNA in the blood than we were able to obtain from those FFPE cores. And so probably that's related to undersampling of the primary tumor. I realize these are only really confirmatory biopsies. This isn't like a templated biopsy that you might do in earlier stage disease. But nevertheless, it's what you have. But equally, there were situations up the other end of the spectrum where we were getting virtually no information from the ctDNA. And the tissue biopsy, while inconsistent, was still providing information. And of course, there's this group in the middle where the results are fairly equivalent. So I would say I'm completely unable to say, well, one is superior to the others. But what you'll be able to see here is that if you relied on only one or the other, you really would miss some information. And so actually, I would love to be able to stand here and say liquid biopsy is the way to go, tissue biopsy is bad. But actually, the two are very complementary in this setting. As you see that at the individual gene level as well. So when we're looking at the detection of specific mutations, here's TP53 that I've mentioned several times. Again, we're seeing one of these mirror plots, mutations that are detected in the ctDNA and whether they're detected in the tissue. And you can see that by and large, a lot of these are very consistent. But there are situations where a liquid biopsy detected a mutation that was either undetectable or there was no tissue available, and vice versa. And in fact, if you kind of sum these up, you can see, well, yes, there's a lot of situations where the results are identical between tissue and ctDNA. But there are situations where either the ctDNA or the tissue identified a critical mutation that the other did not. And mostly, this was not because the tissue biopsy contained tumor cells that didn't have the mutation. It was because the tissue biopsy missed the major foci. And likewise, in the blood, it was because there wasn't enough ctDNA to be able to tell if the mutation was there. So it wasn't, true discordance, but it was sort of negative signal from those tests. But this, this is critical information because this is actually how this, if one did want to use these tools together, you really would have much more information than either in isolation. The same goes through as we look gene by gene, and I could show you a whole list of genes, but an example of DNA repair gene mutations, DDR, DNA damage repair. Similar kind of scenario, the majority are identified both in tissue and ctDNA, but there are some where only the tissue or the ctDNA pick these things up. I'll give you a couple of examples because they're interesting. Actually, the patient with the mismatch repair defect, it was only detected in his blood. And he was the patient that had Gleason 6 on his FFPE diagnostic core. So, and this was a patient where his PSA was above 1,000. He had bone metastases all over his body. So, obviously, everyone in the audience would have drawn the same conclusion, which was the prostate biopsy missed the major foci. Clearly, this guy has explosive disease, but actually, it was the blood biopsy was much better able to pick up the disease characteristics in this patient.
What's that biopsy done? Years ago?
No, it was done. I think it was done the same day as the blood draw, or the day after, maybe. Yeah. But it wouldn't. The patient was still treated the same either way, right? This is a research finding, but I think if you had this information up front, you may consider something like pembrolizumab, which is now a pan-cancer approval for these type of settings. But at the time, that wasn't the case. I want to illustrate, I don't want to show an anecdote where the cell-free DNA performs better without also showing the alternative where the tissue performed better. So here was a patient that had an ATM truncating mutation. So ATM is in the same pathway as BRCA2. You can kind of think of it as another critical DNA repair gene. So this patient had biallelic loss of a DNA repair gene, but we couldn't detect any ctDNA. And he hadn't received prior treatment, so we couldn't blame that. And he actually, it turned out, he had an incredibly high amount of normal cell-free DNA in his blood, and we think that was probably diluting any signal from the ctDNA. And he had pancytopenia at the time of collection, so we think he had massive cell death from other reasons, non-malignant cell death. But again, another lesson in that one can't just apply a liquid biopsy indiscriminately. There are things like this which would throw spanners in the works. I would also point out, one thing that, in case you're thinking otherwise, in the samples where we were able to, in the patients where we were able to get clear ctDNA signals and clear tissue signals at the same time, we found virtually identical results. So if both work well, they provide the same result. So this is showing 26 cases where we were able to get, have very strong results from both situations. There was 80% concordance. So these are looking at mutations in liquid and tissue. These are very specific mutations, and the fact that they're detected independently in both platforms is extremely unlikely in any other scenario. So what are the conclusions here? Well, so plasma ctDNA is abundant in the majority of patients with castrate-sensitive prostate cancer. I think it provides additional insight into metastatic disease beyond that available from just a prostate biopsy, from a genomics point of view. However, exposure to prior therapy, even just a day, significantly reduces the amount of ctDNA. And this impairs detection of any of those clinically relevant or potentially clinically relevant molecular subtypes. So I think, it's not a stretch to say that if ctDNA is going to be of any use to help guide combination approaches, the blood collection timing needs really careful consideration. And I flashed up earlier on some of those New England Journal papers that came out with the Stampede data, with the Latitude data, that were looking at, that showed the benefit for combination of, say, taxane or Abi or others in the castrate-sensitive space. So they all collected plasma at what they determined to be baseline. And so there are huge international efforts right now to look at the circulating tumor DNA in those samples. But I think the vast majority of those patients are already going to be on ADT. And so one of the key lessons that we're trying to get out there at the moment is, beware, basically, because you may overinterpret your data if you're not aware that there's actually very little tumor DNA. So the second part of the conclusions is that the mutations that we're identifying were highly concordant with matched tissue biopsies. So I would say that, perhaps either are suitable for molecular subtyping in this setting, but I think the key take-home message here is that neither ctDNA nor tissue biopsy captures the somatic mutations in all patients. So not just DNA repair defects, P53, other alterations I haven't mentioned that have relevance either for prognosis or potentially for treatment combination may be missed by reliance on just one or the other technique. So I posit that the optimal approach for correlative research studies or biomarker development strategies in this setting really should incorporate both analyses. Otherwise, the risk is we're going to undersample disease from a genomics point of view. And the final point I make is that this disease, which was really remarkably poorly characterized before because of a focus on either radical prostatectomy specimens and localized disease or on late-stage castration-resistant prostate cancer, this represents really the first study to look at the genomics of this intermediate step. It's characterized by genomics that are virtually indistinguishable from the lethal setting with the absence of AR mutations. So I really think this disease primes for CRPC progression, which is why the responses are so brief to androgen deprivation therapy for the majority of these patients. So with that, I'll close. This has been, it's a huge team effort, and so I'm really lucky to have several incredibly talented graduate students in my laboratory. I don't have a single postdoc. I've relied on clinical fellows like Werner Struss, who led a lot of this clinical work here, as well as graduate students in the bioinformatics setting who've done sort of all the pretty pictures that you see here, with the exception of that dodgy cartoon. That was me. So thanks, and we've got a few minutes for questions.